Okay, hopefully this video is going to run through the use of ROTEM just enough that we can understand it for the ACEM exam, and also hopefully give us some more confidence if we have a case we're having to use ROTEM, particularly in the case of an MTP. So you know that you need to do an MTP because somebody is bleeding a lot, there's blood all over the floor, and you think they are going to need a replacement of their entire blood volume either in 24 hours or at least 50% in the next 4 hours. So you activate the MTP. You get these hideous looking guidelines with lots of diagrams, lots of detail and information, and you see the ROTEM and your heart sinks slightly because you've never really committed to memory or fully understood what it's talking about. Hopefully we will address that. So if you activate an MTP, you get 2 boxes. The first box contains 4 units of packed red blood cells, 4 units of FFP, 6 units of cryo. In the second box, you get 4 units of blood cells, 4 units of FFP, and 1 unit of pooled platelets. And then you just keep alternating between them as you go. You can either do a protocol-driven resuscitation where you just give what's in the box, or you can do a slightly more tailored approach where you use ROTEM amongst other things to work out what is it that this patient is missing, and can we target that to replace that. AIM and MTP obviously is to stop the bleeding and to save the patient. There's various targets. Seemingly this is regular exam fodder. You want to keep them warm, and you don't want them to get acidotic, and you want to correct the bleeding. There's the triad of death. The hypothermia and the acidosis in some ways are relatively straightforward to fix. The coagulopathy is a thing that we'll now go into a little bit more detail of. Things to note in here, you want to keep the calcium up. The calcium is going to keep going down the more blood products you give, because all the blood products will have some citrate in them. That citrate will bind to the patient's calcium and drop it. So you're going to have to be fairly regularly replacing with some 10% calcium gluconate. And then platelets, PT, APTT, fibrinogen, INR we'll address as we go through this talk. Each of those things would be helpful. If you're lacking in factor 1, fibrinogen, you can give cryo. That's got fibrinogen in it. If you're lacking in your platelets, which are needed to make your kind of primary platelet clog and strengthen your fibrin mesh, you can give platelets. If you are missing your clotting factors, you can give fresh frozen plasma, which contains all of them, or you can give Beriplex, which again is going to replace 2, 7, 9, and 10. So coming on to ROTEM tests. The only 2 that I'm probably going to be covering are ACEM and FibTem. And that's because they're the ones that are in most of the MTP protocols, and the ones that seemingly most commonly come up in the exam. The INTEM, the HEPTEM, and the APTEM are basically for special circumstances and when patients are on heparin. We're just going to be focused on ACEM and FibTem for this. In terms of what each of the tests do, we're just going to go through them. So ACEM tests the extrinsic pathway. It's very similar to your PT. FibTem is a test of your fibrinogen. So it's exactly the same as the XTEM, but it inhibits the platelet activity. So all you're seeing is how good your fibrinogen is. Hopefully all of this is going to become clearer as we talk through it. what you end up with when you do your ROTEM, the needle goes into the blood goes around, the blood clots, puts pressure on that needle, and then that pressure on the needle is plotted on a graph, and it comes out with a shape looking something like this. The key things to see on this graph. First thing is the clotting time. How long does it take for a clot to actually form? Then you're going to see how long does it take for it to form kind of a clot of any reasonable size. So clotting time is from 0 to 2 millimeters. And then your CFT, your clot formation time, is when it goes from 2 millimeters to 20 millimeters. So that's when you've got a kind of a clot of any reasonable size. If you have a prolonged clotting time, most commonly this is because you have low amounts of fibrinogen, factor 1. Another common reason is that you've got a clotting factor deficiency or you're on anticoagulants. A low CFT doesn't come up all that much actually in the guidelines. Is pretty non-specific. That's either going to be a problem with platelets or platelet function or fibrinogen, and we can tease that out further when we do the FibTem test. So the first thing you're looking at is your clotting time. The next thing you can see on your little ROTEM graph is your clot amplitude. How big can the clot get? And that essentially tells you how strong does your clot become. You can leave a ROTEM cooking for ages and ages and ages. That's not especially helpful to you when blood is still pouring onto the floor. You want quick answers. So in MTP, you can just start doing your standard protocolized stuff first. You send off your ROTEM, and then you can get your results, some useful results back after just 5 minutes. And the result that you can get back after 5 minutes, which is useful, is your A5. And that is your amplitude at 5 minutes. So after 5 minutes of this blood being in the machine and clotting, how strong is the clot that is formed? There's also an A10 and something called your MCF, which is your maximum clot firmness before it starts to degrade. The thing that determines your clot strength is primarily fibrinogen and platelets. So if you're low on your fibrinogen or your platelets, you're going to have a low A5. So we mentioned the two ones that we're going to look at are ACEM and FibTem. ACEM is shown here. This is your basic screening test. They get some blood, they put some tissue factor into it to initiate that extrinsic pathway, and then they see what kind of clot forms. It is a nice basic screening test. And here's what a normal one looks like. You've got a appropriate length of your clotting time. And in this one, it's 47 seconds. Your A5 is 30 millimeters. Again, this kind of good, appropriate A5, good strong clot. In your FibTem, it's the same as your ACEM, but you've deactivated the platelets. So you're only seeing now the effect of the fibrinogen isolated. That's why it's called a FibTem. It's a fibrinogen test. A way that you can potentially remember it is the fibula is long and slender, and the picture that you get in the FibTem is the long, slender one. The measurement that you're looking for on here is the A5 and the A10. The actual clotting time and things like that isn't as helpful, and your maximum clot firmness isn't particularly helpful either because you've taken away the platelets. So you're just looking at the fibrinogen contribution. We'll go through specific values of what's abnormal in just a second. Exactly the same as the last one. So the FibTem is normal, so we know it's not a fibrinogen problem. It's not a fib issue. it's a platelet issue. So we've got impaired platelet function in this one, or low platelets. So this patient would need some platelets. The CFT is slightly prolonged, but as I was saying, that's kind of non-specific. In this one looks very different again. It looks like it started out well and then it's very quickly petered off. This is hyperfibrinolysis. So the problem here is that your fibrin is being degraded. What you need to do is give tranexamic acid. Tranexamic acid stops plasminogen from being activated into plasmin. Plasmin breaks down fibrin clots. So stop the fibrin degradation by giving tranexamic acid. I think entirely possible that they would ask us in the FACEM exam about CRASH 2 trial, because it was a trial I think that came out in 2023, so somewhat recent for us. CRASH 2 was looking at TXA and major trauma. It's excellent if you give it within 1 hour. 1 to 3 hours is okay and infers some benefit. Over 3 hours might actually be harmful, so don't give that. Nice. So going through a department's MTP ROTEM protocol in turn, we can just have a look and see if we can now understand it, given that we know what the ROTEM is doing. This is Charlie's ED, which I think is based out of Perth and often comes up when you're searching for MTP ROTEM protocols. So we can see immediately this is one of those abnormal looking ROTEM shapes. It's looking at the XTEM and a clot has formed and then immediately has kind of degraded and become rubbish. This is what we were just looking at. This is because there is lots of fibrinolysis. You need to give TXA to stop the fibrinolysis from happening. Realistically, in any kind of MTP or massive bleeding, TXA is given almost immediately, so it's pretty rare to see this. If you were to get your ROTEM off beforehand and you saw that and then you repeated it, you would see a corrected ROTEM, which looks much bigger and thicker and better. So give your TXA, 1 gram IV stat, and then you can start an infusion of gram over 8 hours. And the key number on this one is an XTEM under 35. Fibrinogen problems. So if your long, slender fibula is looking even more slender, and they've got a low A5, an A5 that is under 10, this is a fibrinogen problem. Replace the fibrinogen. Where do we get fibrinogen from? We get it from cryoprecipitate. Like I said, in Australia, you can't just get straight fibrinogen, except for rare circumstances, so we give cryo. And just to remind you, 10 to 20 units is about standard. There are some dosing guides of how small your FibTem is. If it's only a little bit small, you only give a little bit of cryo, and if it's a really small A5, then you give more. But 10 to 20, I think, is going to be acceptable for the exam and the practice. So that's fibrinogen. Next, an example of platelet deficiency or dysfunction. Again, we've seen this already, but putting some actual numbers to it. If you had a normal FibTem, the A5 was over 10, but an XTEM where the A5 is under 35, so a weak clot for an XTEM. This shows you that it's a platelet issue and they need some pooled platelets. Very easy, it is 1 dose of pooled platelets. Finally, if they have got a prolonged clotting time, but everything else is relatively normal, they've got a kind of a normal A5 showing a kind of appropriate strength, but a clotting time is an issue. They're going to be low on their clotting factors. So you need to give FFP, which replaces their clotting factors, or Beriplex. Again, to remind you, FFP 4 units is about standard, Beriplex 50 units per kilo, up to 5,000. Good. XTEM, that's low, then you know it's a platelet problem. You can get platelets. Step 3 in this one, look at your clotting time in your XTEM. Is it over 90 seconds? Some guidelines are over 80 seconds. If it's prolonged, taking too long, they need clotting factors. Give FFP or Beriplex. This guideline's a tiny bit old in that it's saying prothrombin X. Like I said, it is now Beriplex, I think, almost everywhere. Good. A way to remember this in the exam might be a little bit silly, but here's a way that I've come up with. Step 1, fibbers. All children under 10 are fibbers and they cry when they get caught. So if your fib 10 is under 10, so under 10s, fibbing, they're going to cry, give cryo. Step 2, XTEM A5 under 35. Most 35-year-olds will have at least one X by that point in their life, and at that stage they may have had some comfort eating off a large plate. So XTEM A5 under 35, give platelets. Finally, your XTEM clotting time, if it's over 90, by the time you get over 90, you will most likely become an X yourself and get put on ice or buried. By ice, I'm talking about fresh frozen plasma, and buried, I'm talking about Beriplex. So hopefully that is a useful visual aid. FibTem under 10, give cryo. XTEM under 35, give platelets. XTEM clotting over 90, give FFP or Beriplex. Hideously big slide here. Have a look at this, because these are the advantages and disadvantages of thromboelastograms, and the advantages and disadvantages of using fixed ratio massive transfusions. This feels like exactly the kind of question they would put into a paper. List the advantages, list the disadvantages. Essentially, advantages of ROTEM are that it's pretty quick. You can get useful answers in 5 minutes. You're not wasting blood products. It's cheaper than wasting blood products. It's becoming increasingly more accessible, and you can demonstrate quite quickly with it that if the patient is still bleeding and you've fixed everything, that it's no longer a medical bleeding problem, but it's like a surgical bleeding problem. This is the surgeon's problem. So that's the advantage of a ROTEM. Disadvantages, it's not as quick as just giving a fixed ratio. You can do that instantly. The testing is more expensive than coag tests. However, it's cheaper than wasting blood products. It requires a lot of maintenance, requires training. You might not get it in small regional centres. They're not always super precise. And it can be confounded by things like hypothermia. Advantages of your fixed ratio massive transfusion: super reproducible, readily available. The only time limiting factor is that you've got to thaw stuff. It's really easy to protocolize. It's just lovely and simple and quick, and is going to be probably not harmful for most people. And you can do ROTEM at the same time. You can start with your fixed ratio and send off your ROTEM. Disadvantages: the 1-to-1-to-1 isn't super evidence-based. it isn't going to work for everybody. It doesn't actually include tranexamic acid, but realistically we do that anyway. And it isn't at all diagnostic, it is just therapeutic. It doesn't tell us what the problem is or how to fix it, it just hopefully fixes